Initiative. We are a registered NGO within the Commonwealth of the Bahamas. We were founded in 2018 by then medical students Agatha Folk Mackey, Hall Dennis, and Janelle Osadabe Brown. So our mission is to bridge the gap between the medical community and between the healthcare professionals and the community through education, outreach, and research. So our term started in September of last year, and so far we've been able to host 2 online lectures. So in October, we were able to host an online lecture about breast cancer awareness with Dr. Dawn Major, a surgical oncologist. And then in November, we were able to host a diabetes awareness lecture with Dr. Christine Parker Curling. And then in December, we hosted our annual charitable event where we were able to give away essential items and serve lunch to the adolescent mothers at the PACE and Adolescent Health Clinic. So with each of our initiatives, we want to be as intentional and purpose-driven as possible. So we decided to host a sexual health panel discussion this month because we believe it's important to facilitate an informative and open discussion about the health topics to encourage regular screenings and safer sex practices. We also want to address common misconceptions to help change the negative stigma surrounding individuals with HIV, AIDS, or STIs. And January is also Cervical Cancer Awareness Month, so we thought it was also fitting to also speak about this. So firstly, I want to thank our esteemed panel for taking time out of their very busy schedules and to share their knowledge and expertise with the general public. I would also like to thank the executive members for their continuous hard work and dedication to the mission of this organization. So our executive members are Ms. Anika Minnis, Vice President, Celeste Stewart, the Secretary, Ms. Gabrielle Evans, the Community Service Officer, Ms. Mavanda Green, the Research Officer, Ms. Ria Rowe, Public Relations Officer, and Ms. Brittany Bonamy, the Treasurer. And personally, I would just like to thank my mother for all the support she's given me, especially with the execution of this event. So we're going to start, and I'd like to bring on Celeste Stewart, our secretary, to introduce our first speaker.
Good evening, everyone, and thank you for coming. Our first speaker is Dr. Nina Graham, a practicing OBGYN specialist, certified forensic gynecologist, PRP practitioner, and health coach, who has a passion for women's health, physical, spiritual, sexual, and mental. She loves to educate on all aspects of women's health through individual consultations, public forums, social media, and group presentations, awareness campaigns, and her website. She's the founder of 2 successful groups on Facebook focused on women's health. They are Her Evolving Journey and the Menopause Lounge. These platforms were not only established to inform, but to also educate, uplift, and inspire. Her philosophy on educating women is, knowledge opens the eyes, liberates and inspires the mind, and creates a desire for change within. She's the founder of Femina, a practice that specializes in women's health and wellness in beautiful Nassau, Bahamas. She operates daily from Femina Clinic in Palmdale and once a week at the Family Medicine Center on Lake Road. She also practices at the Princess Margaret Hospital, where her focus is gyne-oncology prevention. She obtained her high school diploma from St. Augustine's College and her bachelor's degree from Marymount Manhattan College in New York City and medical degree from the University of the West Indies in Trinidad and Tobago. She's a member of the Alpha Chi Honor Society, Who's Who among students in American colleges and universities, Alpha Kappa Alpha Sorority Inc., Northern American Menopausal Society, and the Cellular Medicine Association. During her spare time, she enjoys taking a dip in our beautiful crystal clear beaches, boating, traveling to exotic destinations, listening to jazz and instrumental and R&B, and hanging out at her favorite local spots, and simply snuggling up with her son Israel in front of the TV. Please welcome our first panelist, Dr. Nina Graham.
I tried to. Not successful. Okay. Thank you for that introduction. I didn't know you was going to do the whole one. I say take out little pieces. Do we have one of the pointers or no? This isn't it A? No. Oh, okay. Oh, okay. Okay, so we're going to dim the lights down, or? Y'all ain't gonna go to sleep on me, right? Okay. Can I do it from here, or you have to do it from there to advance? Huh? Sorry? Okay.
Oh, you wanted to?
I wouldn't be able to do it from here, right?
Yeah.
No? Okay.
I mean, if you have your slides on there, you could actually use your laptop and present from your laptop.
Right.
She still works, switch with you.
Okay. No, yeah, I want to be able to advance the slide from me.
No, but I mean, if it's easier for you to read, present from your laptop.
Advance and put a pointer, no?
No, ma'am.
Okay, all right, that's fine. So I guess I'll just nod at you or thanks. Okay, good night, everybody. January is Cervical Cancer Awareness Month, and these are the colors. As you can see, I have my teal. There's blue and green teal for cervix cancer awareness. Okay. So what should you know about cervical cancer? And I am very happy that we have some gentlemen in the audience tonight, because everyone seems to think that cervical cancer only involves women. Yes, it does. Only women have cervixes, but men are indirectly involved, and it's important for them to know that also. Okay, so my presentation, I'm going to try and pack it in 20 minutes. I was told I have 20 minutes. I've never done a presentation in 20 minutes. Mind you, as a student, you're like, 20 minutes? That's too long. All right, so basically I'm going to start with an introduction looking at some of the stats for the Bahamas from the year 2018 to 2021 or 22, I think I have, from the Ministry of Health. Unfortunately, we don't have the latest stats, but I have up to the point the ministry, the statistician gave me. And then I'll go into what is cervical cancer and cervical dysplasia, the cause or etiology of cervical dysplasia and cervical cancer, what is HPV, risk factors for cervical cancer, the pap smear, in terms of, this is a frequent questions, when it's supposed to start, when you're supposed to start doing a pap smear, when do you end, how often are you supposed to have a pap smear, and basically about the pap smear itself, a history on the pap smear, management of abnormal pap smears, presentation of cervical cancer and staging, management of cervical cancer and prevention. Okay, I'm going to try and keep it as non-scientific as possible. So these, first of all, cervical cancer is the #1 cancer involving women, is the #4, cancer involving women worldwide. In the Bahamas, cervical cancer is the #1 cancer of the female reproductive tract. Okay, now breast is #1, but that's not considered the female reproductive tract. Okay, now the incidence per 100,000 population of new cases from the year 2018 to 2021, as we can see here, in the blue is 2018, we had 9.1 cases, and down to 2021 is 5.9. Now, these stats would have been affected by COVID, so it may not be absolutely reflective. Okay, next slide. And of course, the number of cervical cancer cases, death from the year 2018 to 2022. Again, we see a big jump in 2020 and 2019. We had 11 cases, and I think that looks like 15, huh? So these are the stats for the Bahamas. Now, I would say definitely over this last 2023, for about the last 6 months of the year, I have been diagnosing a cervix cancer every week. Every week. Okay, so I'm not sure. My boss and I, we have come to the conclusion that these are the cases from the lockdown, from COVID. But it's every week, advanced cervical cancer cases. Okay, so as you can see, it's definitely not just a health burden, but it's an economic burden for the Bahamas, as the government basically takes on most of the radiation costs for our public cervical cancer cases. The cost of radiation is in excess of $15,000, and radiation is not a public management tool that we have. Radiation is done publicly, so their monies have to come up front. Okay? I want to say that cervical cancer is absolutely preventable. That's the hard part. It's preventable, and our women are not getting their pap smears. And when I speak, it takes about, let's say at most, between testing and the lab, let's say $150 a year for a patient. Okay, a lady. So $150 a year versus $15,000. And I have seen women die because they can't afford radiation and they only get chemo. And the best chance of management is chemo radiation. Okay, so what is cervical cancer or cervical dysplasia first? Normally you have dysplasia and then it advances to cervical cancer if no treatment is done. All right, so this is a slide of basically, I try to mimic this picture, but I'm not a good artist. But when I have a patient in front of me, I normally try and show them dysplastic cells. So basically, if you see the normal, okay, you have squamous cells at the top, and they're like in stacks. And all these cells of the cervix is on a basement membrane that buffers them, so to speak. So there are changes that these abnormal cells go through before it becomes cancerous. And as this slide shows, the dysplastic cells or the abnormal cells break through this basement membrane or that buffering layer. When it gets into the blood system, that is cancer. Okay, so you have stages, and the thing is, cervical cancer is very slow growing if you get it at the beginning. And if you do nothing, it's very slow growing. So you have many, well, not many, but you have some years between to pick up the abnormal cells and to do something about it before it advances to cancer. As I said, cervical cancer is preventable, and it is preventable because you're able to pick up these abnormal cells by doing your pap smear. Okay, next slide. All right, so this is basically cervical cancer. So it has broken through the basement membrane and gone into the blood system, and it goes locally where you have the first stages, right there in the cervix, and then it advances further out into the pelvis, and then at stage 4, it's a distant spread. Okay, so that is what cervical cancer is, and this is all occurring at the cervix. That's for men, that's the neck of the womb, that's the area that dilates to have the baby. Okay. All right, next slide. So what is the cause of cervical cancer? HPV. All right, HPV stands for the human papillomavirus. And this is where our sexual health comes in. All right, now the human papillomavirus is a double strand. I don't want to go into the little nitty gritty, but it's a virus. It's a double-stranded DNA virus. And it is sexually transmitted. So just how all the other sexual diseases occur and the risk factors involved in those is the same way that HPV occurs. Can I have the next slide? Now, the human papillomavirus has many subtypes. It has over 100 subtypes, but not all of them are cancer causing. Okay, in terms of the most common subtypes for cervical cancer are 16 and 18. They have numbers. We have first and last names, they have numbers. Okay, so the 16 and 18 are the more common ones that cause cervical cancer and cervical dysplasia. And then it's the 6 and 11 that cause genital warts. Same virus, just a family. All right, so the 6 and 11 are the common ones that cause genital warts. 16 and 18 are the ones that cause cervical dysplasia and cervical cancer. Now, there are others, and I'll speak more about the vaccine when we talk about prevention, but there are other subtypes that have been becoming more, I shouldn't say more common, but have been coming up in terms of being a popular subtype. And so when we look at the Gardasil or the vaccine, you're going to see we have one that started off with those 4 common subtypes, 6, 11, 16, and 18, and then it's now the Gardasil 9 that has additional subtypes. So for the men out here, and as I mentioned, the HPV does not only affect the cervix. So a lot of times I have a lady in the front of me and she says, oh, well, just take out the uterus, just take it out, take it out. You know, I'm tired of getting managed with abnormal pap smears, okay? And I have to explain to her, yeah, we can take it out, but the human papillomavirus don't only affect the cervix, it affects the vagina, the vulva, the anus, and the throat. All right, and as a matter of fact, the cases of oropharyngeal cancer have increased over the years, previously known to be caused by smoking, and it has been overtaken by HPV. Okay, so I have to explain to my women, yes, we can take out your uterus with your cervix, but bear in mind, if you have a persistent infection, and we have had cases where that happened, where they had cervical cancer, they had a persistent HPV infection and came back with vaginal cancer. All right, so yeah, we could take out the uterus with the cervix, but be aware, and that doesn't mean that you could stop doing your pap smears. By the way, ladies, I continue doing pap smears after you have a hysterectomy. I do a vault smear, especially if you had a history of cervical dysplasia and HPV, because we still have to monitor you for vaginal cancer. Okay? So yes, that slide is showing the other cancers that are involved, and your oropharyngeal falls in the head and neck, and men also get penile cancers. Okay, and if she have it, you have it, or you, whatever, you know. I can't say which way, but the men are the carriers, and the men cannot be tested, can't do pap smears on men. All right, next slide. So risk factors. A risk factor is something that will increase your chance of developing cervical cancer. There are modifiable and non-modifiable risk factors. You would find the more modifiable risk factors to be more than the non-modifiable. Okay, next. So these are some of the risk factors associated with cervical cancer. Now, an infection, as I mentioned, with a high-risk HPV, which are the 16, the 18, the 33, 35. Y'all students remember all of them? Y'all ain't remember the high-risk ones? Y'all ain't come to me yet, eh? All right. So high-risk HPV types, just remember that the low-risk ones are the 6 and 11, which cause genital warts. But when you come to me, you need to know all of them, okay? Early onset of sexual activity, your sexual debut, how old were you? All right, so if you start at the age of 14, then the chances are that you would have had more sexual partners or more times that you had sexual intercourse between the age of 14 and 21 versus someone who started at 18, 21, when only had 2 years. Okay, multiple sexual partners. But bear in mind, you can contract HPV from your first sexual encounter. Okay, I had a poor lady come from one of the clinics, very guarded, almost near tears. And she sat in front of me because she was referred for an abnormal pap smear. And I was like, you know, it's important to have a rapport with your patient. And she came there guarded. I was like, well, what I do? Does she know me? And I started to ask, and I always say, listen, I have to ask you some personal question. I ain't trying to get in your business. I just need to assess your risks. This is a risk factor assessment. And I asked about partners, and she was very guarded, didn't want to answer the questions. I said, wait a minute, hold up. I said, now, the only way I can help you is if you give me the information I need. Why are you acting like this? And she burst out crying and say how the nurse at the clinic was implying that she run around, and miss, I don't run around, and da-da-da-da. And I was like, hold up, I don't, that's not, and I had to explain to her why I was asking these questions. And I was not implying that she was a run around and a fast person. I said, but we need to assess risk. This is a tool. And after explaining everything to her, she understood. She's one of my best friends now. But a lot of times, as physicians, when you guys get there, you cannot stigmatize people. All right? And you need to just get your information and explain to them that this is important for this. And take the extra 2 to 3 minutes to discuss it with her. And you will get what you need. Okay? So multiple sexual partners, yes. But that does not mean that you cannot contract HPV from your first sexual encounter. Cigarette smoking, it has to do with the life cycle of the cell. It makes the cells of the cervix more susceptible. It also causes almost like an immunocompromised state, as well as being immunocompromised. Any conditions like HIV, diabetes, anyone who have had transplant, kidney disease, all of these things make you more susceptible or increase your risk for cervical cancer or cervical dysplasia. And of course, a low socioeconomic status. Most women, well, I don't know, because you have women who don't work, who do their nails and their hair and go away and still don't come do their pap smear. So, I don't know. Next. I wouldn't comment on that. Next. Next slide. Okay, so everybody here knows what a pap smear is, right? So it was invented by Papa Niccolo many years ago as the first screening tool for cervical cancer, and it has been tried and true, and it is the only screening test that can give you a snapshot that, hey, you can possibly get cervical cancer. There are no good tumor markers out there for cervical cancer. And so the pap smear is the tool. Remember, cervical cancer is preventable. Okay, so let's go on to what abnormal pap smears and how we manage that. Next. Okay, so on a pap test, you may have normal, but these are the abnormal things that can come on your pap test. Okay, I'm not going to go into what LSIL and all of those means, but basically, next slide. It basically grades your pre-cancer cells or your dysplasia. And by doing that, we know that we have to go further. You know that the pap smear is only a screening test, and it has to be confirmed by a biopsy tissue. And that's where your colposcopy comes in, which is the next step. Okay, what is a, really? What? I didn't see that on my last presentation. Okay, so basically a colposcopy is looking at the cervix closer with this apparatus here called a colposcope. And basically this thing here looks like binoculars, right? So basically you look through those binoculars and it enlarges the cervix. It gives you a good picture. You can talk about the vessels, how the cells look, okay? The cervix is supposed to have a pink appearance. And when you look through there, when you do a colposcopy, the normal pink appearance of your cervix, the abnormal areas, as I had earlier, the L-cell, H-cell, if you have any of those, what a colposcopy is that you introduce solutions on the cervix to help identify the abnormal areas. So the nice pink cells will appear. The first thing we do is we put acetic acid on it or household vinegar. Basically, the abnormal areas will look white. All right? And then we put something called Lugol's iodine on it, which makes that same area look yellow. So you know the area that you're going to biopsy. Again, you need tissue. You have your screening test, the pap test, then you have a colposcopy where you get tissue. Next slide. And on a colposcopy, you're going to get these it's basically 1, 2, and 3. That's all you need to know, right? But they grade it like that. So you're getting a grade of how severe or how much abnormal cells we found on colposcopy. Now, as you can see, the normal cells have a small nucleus, or that little red dot. That's the nucleus of the cell. And as you get more dysplasia or abnormality, then you see the nucleus looks a little bizarre and big and ugly looking. So that's your severe dysplasia. And if it persists, like they say, every 5 to 20 years, remember I tell you it's slow growing, but in the Bahamas I find it goes to invasion much quicker than 20 years. But normally I see between 5 and 7 years. If you do nothing, that is. Okay? So again, they're showing you the stages of dysplasia or abnormal cells. And at these stages is where you can have treatment if you get your pap smear and then get your colposcopy. But a lot of women just don't show up. As a matter of fact, most of the cervical cancers I diagnose gives me the same story. I haven't had a pap smear since my last child. And, during COVID, I was like, okay, I can forgive you. That's 2 years, so that's fine. And I'm hoping their last child is 2 and 3 and maybe 4. The most I have gotten is 30. 30, okay? And some women say, I never had a pap smear, right? So, next. So here, you see where the burden comes in. And so this is how we treat. We either excise the abnormal tissue, either by, this is cold knife, cold knife, or a leap. Now, both of these are office procedures. A leap basically takes a wire and it's connected up to an electrical current, and you basically cut off the abnormal portion of the cervix. This one is, this isn't an office procedure, this is in the theater. And basically the cone biopsy is just what it sounds like. It's a cone, so it looks like this. These are more for deeper lesions. All right, so we saw a picture of the cervix. It looks like this. Right, so what you're doing is you're trying to get deeper lesions with these. Okay, so either you can go very deep with the cold knife, or if you're in the office, you may have to take more than one bite. But again, you're trying to get the lesion that's in the endocervical or in the cervix. Next, whereas the other one, next. These are, go to the next one and I'll go back to that, sorry. Right, these are destructive ways of management. So what we do is these are on the outer portion of the cervix. So these, you may have an abnormality from your colposcopy, either on the outside or in the inside. And from there you could decide what type of therapy you're gonna use. Now, for women who don't have kids, and who have one and plans on having more, I tend to do this procedure first, because as you can see, the little nipple there can only go so far. So if usually after the exam or the procedure, we repeat your pap smear in 6 months. If it's still abnormal, that means the lesion is deeper. So I try to start with this because there's an element of cervical incompetence, or for you guys, for someone who may have had an excisional procedure, she may silently dilate in early pregnancy and lose a pregnancy. So the neck of the womb is not as strong as it should be due to the procedure. Okay? Can you go back to the right? So when you're looking at the destructive method versus the excisional procedure, you can see that it's basically similar in terms of curative rate, and your management is pretty similar. So I have patients normally ask me, okay, doctor, which one you suggest? And I was like, the two are basically the same. But again, I look at whether she's had children, she plans to have more children, is she a candidate for theater, that type of thing. Okay, so it basically depends on the patient. And then, of course, if she has a low threshold for pain, I take it on theater. All right, because when you do the LEAP procedure in the office, if they're nervous and they're jumpy, I had one patient where I went in her bladder because she jumped. All right, so there are complications if you don't keep still. Now, it is under local, but sometimes patients come in with their preconceived notions. They talk to their friend, they come in there like afraid, and that doesn't work for the two of us. Okay, so you have to look at all of these factors when you're managing a patient like that. Next. Okay, so again, we go back to this nice little diagram of, again, CIN 1 straight up to 3. And this is another picture. And then, of course, if you leave this on the other side, they said 5 to 20 years, but 5 years at least, it's going to break through the basement membrane and go into the blood, and that's cancer. Next. So what are some of the warning signs of cervical cancer? Well, let's go back to cervical dysplasia. And early cervical cancer, there's no sign, asymptomatic. All right? You don't have to. And usually when women come in, they come in with bleeding or an odor. All right? That is what runs them there. And when you're to the point where you're bleeding heavy, like a period or more, or you have this cervical cancer has a distinct odor. When you coming in and your partner run you because you smell, you miss the boat. You're bleeding heavily, you miss the boat. Okay, we want you to get in on board at the abnormal pap smear stage. So you can have all sorts of bleeding after sex, bleeding between the periods, heavy bleeding, postmenopausal bleeding. And ladies, when you see your period, after your periods stop for 1 year, you are not getting younger again. That is a myth, and something is wrong. Okay, I have had women come in and say, but they say I have my Facebook page on the Menopause Lounge, and a lady came on and said, oh, wow, I feel young again. I started to get my period and da-da-da-da-da, and she going off for pads, and she wanted us to, right on there, I had to say, hold up, that's not a good sign. I need you to go see your doctor, so. And she was like shocked. Because in our generation, they tell you, or in that generation, that getting your period again, you're young again. No, ma'am. Okay, that's wrong. And bleeding, you can get bleeding from every cancer of the female reproductive tract. So the ovaries, the uterus, the cervix, the vagina, all of them present with abnormal bleeding. So don't look at me cross-eyed if I want to sample your uterus. Okay? A lady that comes in with bleeding, I can do a pap smear. If she's less than 65, that's the cervix. I'm gonna visualize the vagina, make sure there are no lesions there. I'm going to look at the cervix, make sure her pap smear is normal. I'm going to get an endometrial biopsy looking at the uterus, make sure that's normal. I'm going to do a scan to look at your ovaries. And I'm going to do a CA-125, which is a tumor marker for ovary and uterus. Okay? So, and on one of the pap smears, you do that also, and that's an agas. All right? Because you have to know it's atypical glandular cells, and you have glandular cells from the ovaries straight down, so you have to investigate the whole thing. All right? And again, your unusual malodorous vaginal discharge. Those are the two main presentations you need to know about next. And again, I had this on before. These are the stages of cervical cancer. All right. The first stage you may be able, the first stage is divided into 1A and B and A1 and all of that. If you have an early stage 1A, you can get away with surgery. It depends on whether the abnormal cells or the cancer has gone to the side walls. If it is a certain size, surgery is no longer an option. So we get patients who are stage 2, all right, and they be like, well, why can't I have surgery and just take this out? No, you missed the boat. All right, so you need to do chemoradiation. That's the sorry, go. The treatment is the next one. Sorry. Right, those are your options there: surgery, radiation, and chemoradiation. Right, and we normally manage our patients with chemoradiation. So not only do you have to come up with $15,000 for your radiation, but you have to pay for chemo also. Go back to the 5-year survival rate. As you can see, the survival rate at stage 1 is much better than a stage 4. Okay? All right, next. So it's important to do your pap smears, and if you do have cancer, for you to manage those as quickly as possible. So according to WHO, cervical cancer is the most preventable and treatable cancer. All right. Yet in 2020, more than 600,000 women were diagnosed with cervical cancer worldwide, and almost 350 died. Okay. It is preventable through screening, all right, and vaccinations. Those are the key ways in which cervical cancer is prevented. There has been a mandate on the Office of the Spouse of the Prime Minister of all CARICOM countries, in which ours is one, to reduce cervical cancer by the year of 2030. Y'all think we can reach that? All right, everybody has a part to play. I try. I have been doing my cervical campaign for the last 5 years before I knew about the mandate. But everybody needs to do their part in order to do that. Now, I know the ministry is trying to do it from the kids level, and we're going to go over that when we talk about the vaccine next. These are some of the ways for prevention: the HPV vaccine, the pap smear, and in doing your pap smears, you need to do your regular checkups, right? You need to do your annuals. Some women say, I have to do it every year. I have to do a pap smear every year, right? I know it's uncomfortable, but you only got to do it once a year. Now, we don't really have guidelines as to how often we need to do pap smears. In the United States, they do it every 3 years. All right, they can get away with that. All right, they have HPV testing, they have thin prep, they have call and recall systems. They have a lot more things and different tools that we don't have. And so anytime you come to me, I'm going to pap you, especially if I don't know you. All right? I'm going to pap you. If you are a patient, a long-standing patient of mine, and I've been doing pap smears on you for like 5 years or whatever, and it's been fine, then if she says, Doc, I could take a break, I don't have to, I'll be like, yeah, we could do next year. But every other year for me. But the problem is where, especially how some patients live on the island and stuff like that, you don't encounter them often. So every time I see a lady, I would pap them, but it's not necessary all the time to do it every year. Okay, next. And these are the vaccines available. I'm not sure how much Cervical we have here, but we do have the Gardasil and the Gardasil 9. All right, students, those are the ones there. All right, 31, 33, 45, 52, and 58. Right? Both are for males and females, but the one that was really created for the males is the Gardasil 9. Okay, and the vaccines are given, the Gardasil are given 3 doses over a 6-month period. All right, and they are very expensive, by the way, and they're not covered by insurance. Next. And that's just a picture of them. Next. 9. And that's the quadrivalent one, which is 6, 11, 16, and 18. Next. Now, there was a study done by Johns Hopkins that gives the reason why parents now, what they plan to do in order to eradicate cervical cancer in the future is they have started a campaign on vaccinating girls and boys at the age between the ages of 10 and 12. That's providing that, that's good, providing that these girls or boys are not sexually active before that age, but you may have some where they encounter sexual activity prior, be it through molestation or whatever, that they actually encounter their sexual debut is prior to the age of 9. But these are the reasons why they have found that parents choose not to give the vaccine to their kids. And one of the top reasons is that they feel that it's not necessary. And 17 is the physician. So for those of you who are budding pediatricians, please remember, especially during the month of January, to pick up your campaign on the kids with their HPV vaccines. Next. And that is basically my presentation. This is a slide of my campaign to get PAP during Prevention Week, which is between the 22nd and 27th. For those of you, if you haven't had your PAP yet, your PAP is done between the ages of 21 and 65. We're offering a special at $60 for your PAP. I offer my services free, and this is the lab fee and handling. Okay, so I try to do my part, and if you know anyone who needs a PAP for a lower cost, they're welcome to come to my clinic this week and get PAP'd. Next, another way you can raise awareness is we encourage our patients and people who are on any of my social media pages to wear teal on Fridays during the month of January. And it's called Teal Fridays. Next. All right, thank you. Any questions?
Good evening. Sorry I didn't get your name. I came here.
Dr. Graham.
Dr. Graham. Before I came here, I had a conversation with someone who was in their 60s. And she said, well, my doctor told me, well, 2 things. Because I was that age, which you mentioned, I don't have to have a pap smear. And also because my husband is dead. So I became a nun. So what happens is, you said you don't have to have a pap smear at the age of 65. After age 65. What if the person is still having
Sexual relations?
Yes.
Technically, no, they don't, according to the guidelines. But of course, if they find that they're bleeding, then I would do a PAP. Like I said, I would investigate every area. So, but I don't want you to think because your husband is not alive and you may not be sexually active now that you cannot develop cervical cancer. How HPV is sometimes you have a persistent infection. right, that you may have had before, and because you were younger, your immune system was better, it didn't surface. That's how viruses work. They go in the cell and they turn around things and they make it, you wouldn't recognize the cell after. All right, so I would still, if she presents with any symptoms, then I would do a PAP, I would do an endometrial biopsy, I would do an ultrasound, I'd do tumor markers. Yeah.
Okay, thank you.
You're welcome.
There was a question on the YouTube Live. It states, is the odor or bleeding you spoke about as one of the symptoms something that occurs often when it starts or it goes away?
Sorry, the odor?
The odor or the bleeding that you spoke about as one of the symptoms, something that occurs often when it starts or it goes away. Starts or it goes away.
It can go away after treatment. If you're diagnosed with cancer, right, and you have treatment, the chemoradiation, you may get less bleeding. And you may not have the odor. Okay? Any other questions? But if you don't get any treatment, no dying stuff. Nope.
Thank you. That's
All
it.
right.
So thank you, Dr. Graham, for that very informative lecture on cervical cancer. So good evening, everyone. So my name is Gabrielle Evans, and I serve as the Community Service Officer for this organization, and I'll be presenting the second speaker. So Dr. Norad Morgan obtained a Bachelor's of Science degree in biochemistry and a Bachelor of Arts degree in music from Bellard College, Bellard, Wisconsin. Dr. Morgan studied medicine at the University of the West Indies, Mona, Jamaica, and studied immunology at Trinity College, University of Dublin, Republic of Ireland. Dr. Morgan is presently clinical medical officer in the Department of Immunology, Infectious Disease in the Ministry of Health, and also practices medicine privately at Emmanuel Medical Center. He is married to Dr. Michelle McLean Morgan, and the couple has 2 daughters. So everyone, I would like for you to welcome Dr. Morgan as he speaks on STIs.
Thank you so much. Oh, sorry. So when you present STIs, you really never know what your audience would be. And I can recall looking over here, Gabby, you said these are your parents or grandparents?
So this is Cassius, my grandparents.
Those are, yeah, Cassius. So I never know what to expect. I remember I did a men's health, oh, I have to speak in it? Okay. I did a men's health talk at a church in my diocese. And I thought, a part of that men's health talk was to get into STIs. And when I stepped into the room, I saw my priest, I saw the bishop of the diocese, and I saw another priest who practically grew me up. And I was like, Lord, how am I going to talk about STIs in this setting? I got through it, and I have to step forward and do what I have to do. But I say that to say that STIs is a very taboo topic. And STIs affect adolescents straight up to the elderly. I could say that, right? To the elderly, right? Because adolescents are having sex, older people are having sex. And so it shouldn't be a topic that we're uncomfortable, especially young physicians. It shouldn't be a topic that you're uncomfortable speaking about and addressing in clinical settings. It should be something that you address straightforward, because sexual health is still health. Mental health is health. Physical health is health. And so It needs to be addressed. And so why are sexually transmitted infections important? Sexually transmitted infections are important because many of them have complications. Dr. Graham started out by talking about HPV. HPV has consequences. It's a sexually transmitted infection that has the potential to transform cells. So you progress from the infection, albeit in your younger years, you may be able to clear it if you have an intact immune system. But should you not clear it because of certain circumstances, immunocompromised state, or for whatever reason, and if it is a cancer-causing strain, you can get cervical cancer. So STI awareness is very important. Other instances, chlamydia and gonorrhea in young females, the sequelae or the consequences of having that sexually transmitted infection untreated can cause things like pelvic inflammatory disease, where other parts of the female reproductive tract could get infected and cause pain, cause all kinds of complications. And then we have to think about infertility, right? Infection and scarring of the female reproductive tract, right, can cause infertility later down. So someone in their 17, 18 gets an untreated chlamydial infection, down the line, they'll have problems with fertility. And so you have to address STIs, and they're very critical. And what I do in my practice is, even if I'm speaking to an elderly gentleman may come for his physical, or middle-aged gentleman may come for his physical, I get all that cholesterol and diabetes, hypertension out the way, and I speak frankly. I speak frankly to them. I say, listen, I know you're here, I know you're married, I know you're a deacon in the church, I know you're a pastor, we have a pastor here, right? I said, would you like me to, do you have any other partners? And surprisingly enough, a lot of them do have partners, right? It's a very taboo subject, and I see they do. And then I will ask them, would you like to do an STI panel? And then, I always talk about HIV too, because we always talk about missed opportunity. If you don't screen for STIs, especially HIV, you're not going to know. And they're going to present to you in late stages. Just like Dr. Nina talked about cervical cancer in late stages, HIV progresses to AIDS, which is a late stage. And so a lot of our STIs are treatable, they are preventable, right? And so STI awareness is very important. Young physicians, when you're in that examination room, as Dr. Graham said again, develop a rapport. It's a very sensitive topic. A lot of people, it takes them so much mind power to actually get in your office, right? You have to take a proper history, because that's important, right? You have to ask sexual partners, you have to ask intimate things, right? You have to ask also about mental health. We know that a lot of mental conditions are associated with behavior. You have to talk about behavior, right? Doc, I have some water too. Right? You have to talk about behavior. You have to ask a man, do you sleep with men, women, or both? These are sensitive topics that you have to still address, right? I manage a few transgenders. We're in 2023. These persons are in our healthcare system, and we have to manage them with respect, with dignity, and with confidentiality. Another thing with STIs is confidentiality. When our nurses who are here do contact tracing, sometimes you're like, boy, they may call a name that you know. They may call a high-profile name. They may call a family member. You have to deal with that in a very confidential manner. STIs are very sensitive, especially when you're talking HIV, the topic Dr. Forbes would go into. Okay, that's my little introduction. I'm going to move on now. All right, so they're spread from person to person through intimate contact. I'm wondering if is it possible I could move here? I have to talk in the mic? I have to talk in the mic. Because we're on live, okay. Okay. They're easily spread from person to person through sexual intercourse. In your history, you have to ask about oral, genital, anal ways, right? You have to ask these sensitive information. And I forgot to say, when you're examining them, and for those listening live, your physician may actually tell you to take off all your clothing. What I usually do, especially if I'm meeting a patient for the first time, I tell them, as a part of my physical examination, obviously with a nurse or a PCA in the room, I'm going to be examining you thoroughly, and I'm going to look at your private parts in your genital region and around the anus, especially men who have sex with men, right? Practice anal intercourse, right? So you have to be sensitive to a lot of the STIs that I'm going to talk about, herpes, anal warts. I'm seeing a lot of anal warts nowadays, and so the whole experience is a very sensitive one. And so thorough examination in good light so you could see. And you'll be surprised what you pick up, because a lot of patients, even though they're in your office, it's a very sensitive situation. And so they're not going to tell you everything. So sometimes it's on you to find out what's going on. And they'll say, Doc, man, I had this bump for about 2-3 weeks now. I thought it was a shaving bump. But when you look closer, it may be a lesion from herpes. It may be a genital wart, albeit it may also be a hemorrhoid or a skin tie. But you as a physician need to ascertain that. They won't be forthcoming in telling you they have a wart there, right? Next slide. Right? So in the adolescent, I know a lot of you have cousins and you have grandchildren and stuff. In the adolescent age, we see an increased risk in sexual behavior. And between 15 and 29, you have a peak of the incidence and prevalence of STIs. Rapid physical growth, secondary sex characteristics, they're coming into their own, they're curious, and we live in an age now where they know a lot. I was driving yesterday, and it was very disturbing. I had to go home and tell my wife I passed 3 schools, and what I heard coming out the mouths of children walking from school, and 3 schools before I reached my office. It is, you know, it's mind-boggling, right? It's mind-boggling. So our kids are very advanced. They have access to phones and devices. They're watching pornography. They're texting and sexting, and they have access to a lot of stuff. And so they're very explorative in their thinking, and so they want to try new things. And then we have a culture in our country too where older adults are now having sex with younger adults. So, you know, as my wife Michelle also always says, from we were working in medicine, she did family medicine residency, she's like, boy, you know, medicine, and sometimes when you're dealing with STIs, sometimes show you sometimes the worst of human beings, right? Yeah, you have to be very honest with it. A lot of dishonesty and a lot of things that happen. And that is why I say, when I introduce myself, I'm Dr. Morgan. I am a doctor, and I see STI and HIV. I kind of pause because, and you see their face kind of like drop, and you know, it's not a very glamorous thing that I do. Next slide. Right? And STIs are very important. Why are they also important? Because you have a lot of STIs, if not treated, sets you up for getting HIV, right? A lot of the STIs that present with ulcers are perfect setup for getting HIV, right? You're already having the behavioral patterns, multiple partners, not condomizing, not abstaining. That's a behavioral risk factor. And then you add on that having an STI that goes untreated, right? Don't forget, ulcers bleed easy, right? They bleed easy, and so that's a perfect setup for the transmission of HIV down the line, right? So if you could get to these STIs by screening and by treating them in a timely manner, right, that's one way to prevent HIV. Next slide. All right, and I spoke about all of these things, and we have to always think about the mental health of a client. I'm noticing that a lot. When you go in there, sometimes a basic physical exam can turn into a very complex experience. They just come there for their annual physical. They say, Doc, I'm using my insurance, I use it for the year. But when you start to talk, you kind of figure out mental health issues, and then you go into the sexual health, right? And you notice there are the two occurring. So being a doctor, young physicians in 2023 is complex. It's complicated if you do it right? And sometimes you just can't bypass. But thank God we have a lot of specialists in country now, a lot of mental health specialists now in country. You could refer if you feel that you cannot deal with it. There is help. But a lot of mental health conditions, anxiety and depression, are attached to particular sexual behaviors. And this is just a reality, right? As doctors, we don't judge. Try to keep a straight face. Someone say something, don't, you just write and said, always with compassion, always with, a caring heart, deal with issues. Because a lot of people are going through a lot. And a lot of people a lot of people are in circumstances, right, that they cannot get out and puts them at risk, right? Cultural things could set someone up for getting an STI. A lot of females are in relationships where they can't speak out, they can't get out, they have no control over their bodies, right? Right here in the Bahamas. We see it in other parts of the world more so. But right here in the Bahamas, a lot of people transact sex, right, for money. That's a reality. And that is a setup. I could say personally that during the pandemic when things were hard, a lot of people opened up to me, said, Doc, I had to do this and I have to do it. This is what we deal with. This is the realness of being a physician in 2023, right? Next slide. 2024, I keep saying 2023. Right? So these are some of the common STIs. So I know the medical students always like facts and stuff, but as Dr. Graham said, I'm going to tailor it down. I'm going to try to keep it simple and not too heavy on science and medicine. So these are the usual suspects: chlamydia, gonorrhea, herpes, warts, hepatitis B. I won't go into all of these. I'll just move as quickly as possible through these. And some of the pictures are not very pretty, but they're real, right? And for those viewing live, you could get a look at this. Next slide. So this is chlamydia. Chlamydia is the most common bacterial infection, right? There's a long incubation period. Chlamydia is one of those pathogens that nice. All of this is a consequence of chlamydia. And so when I give this talk to UB students, high school students, church youth groups, I use C word, consequence. Consequence of not practicing safe sex. Next slide. All right. We won't go through all of that. We won't go through all of that, right? Mother-to-child transmission is very important, and it is something that we, they screen in the obstetric services and they treat, so we don't have to deal with that. Now, remember, some of these sexually transmitted infections are based, wherever you have the infection is based on your sexual practice. Not all sex is vaginal. Some sex is anal, some sex is oral, right? And so if you have you could have chlamydial infection in the throat, right? You could have chlamydial infection in the anus, right? Men who have sex with men have anal sex. Some females have anal sex, right? And so that will be where the sexual infection is. Next slide. All right. Young age is common. Male and female, about equal in terms of incidence, right? And then we have to always think about socioeconomic factors when we talk about sexually transmitted infections. As I said, a lot of people exchange sex for money, men and women. And so this should be a part of the history also. Next slide. All right. A long incubation period. Many infections, subclinical means you even didn't know you have it, right? Now, males, a lot of males may present quicker than female. Now, how my wife puts it is that the same organ we men have sex with, we urinate out of. So that may be one of the reasons why, when it comes to chlamydia and gonorrhea, we will, it burns. We may have a discharge, right? We may have abdominal pain, fever, all these things. And so we run to the doctor quicker than probably a female would. Right, Dr. Folks? Dr. Folks, right? Okay. And so Dr. Nina had mentioned that the cervix should look nice and pink. You see how that cervix there looks inflamed and red, right? And this is pharyngeal chlamydia, which I've seen before, right? So it does occur. It does occur. Or you may have a normal exam, right? Patient may be asymptomatic with chlamydial infection. Next slide. All right. Now, gonorrhea and chlamydia, we usually treat together. The presentation is similar, if I could simplify it in that way. Right? Female to male ratio, 2-to-1. And we see a lot of gonorrhea and chlamydia I'm starting to see a lot of it in men who have sex with men. Starting to see a lot of anal gonorrhea, right? And anal chlamydia, where they may present with a discharge from the rectum, pain, tenderness, and as I said, a discharge from the rectum. Next slide. 2 to 5 days. So after about 5 days, men will come and say, I'm burning, I'm uncomfortable. Doc, it feels like there are 10,000 needles sticking me when I urinate. Or they may come with a discharge. The discharge may be yellow, it may be scant in some. I've seen, it may be yellow, it may be green. Sometimes it's a lot, right? That will bring a man to the doctor right away, right? Okay? And burning when they urinate. And chlamydia and gonorrhea symptoms are similar in females, right? And so if you're having anal sex, all the symptoms will be confined to the anus, right? Itching, burning, you may even have bleeding, all right? Okay? Pharyngeal, you may have a sore throat, right? And so sometimes I've found that if you're treating someone for pharyngitis or tonsillitis, you see exudates there, you may just treat, okay, this is a run-of-the-mill tonsillitis. But sometimes they may say, Doc, it's been a week or 2 and nothing is resolving. You bring them in sometimes. If you didn't get a proper sexual history the first time, you bring them in, okay, do you have oral sex? What are your sexual practices? And sometimes you will treat for gonorrhea, which is a shot, and for chlamydia it's a tablet. I won't get into all of that treatment. But within 2 days, the thing clears up, right? So practices, right? And you see this stuff. I don't know if those on live could see. Not very comforting pictures, not very tasteful pictures, but this is what we deal with as physicians, and you will deal with as as physicians. And remember, if you have anal gonorrhea, chlamydia, sometimes that's also a setup for HIV infection, right? Because of all the inflammation and the friability of the tissue, all of these things you have to think about. So, one infection could predispose to the next. All right, next. So syphilis is a very interesting, I'm trying to simplify it. Syphilis is on the rise, right? At one point we used to see it more in men who had sex with men, but I'm now seeing it, I could tell you anecdotally, in heterosexual women, heterosexual men. It's very common, right? And there are rising rates in men who had sex with men who have sex with men, right? Next slide. Okay. It's sexually transmitted. There's stages to syphilis, just like there's stages for cervical cancer. The first stage, you may just have a little sore on the penis, right? Or a little sore on the labia or on the vagina. And it's painless. You don't feel it, right? It may bleed. It may not bleed. But the strange thing about that is that it may go on its own, right? And you may not even notice it. Some people say, Doc, I was shaving and I cut myself, right? And so that's the first stage, which we call primary syphilis. It may go unnoticed. You may not feel it, right? Or you may see it, overlook it, and guess what the tricky thing is? And syphilis is a very tricky thing. It could resolve on its own. It resolves on its own without treatment within a week or two, right? It resolves on its own. So you completely disregard that. That ain't nothing, a little shaving bump, right? But the second stage now, because remember the syphilis wasn't treated because you disregarded that little sore, is where you could get lesions or rash around the body, right? Over the body. It could be in the palms of the hands, the soles of the feet, right? And then there's a third stage if that's not treated. And guess what? Those rashes, you'll be surprised. Some people don't even present to the doctor with those rashes. I think that will tell you I need to go to the physician. But that could resolve on its own too, right? That could resolve on its own. And guess what? Now you progress to the third stage where now what? The heart could be affected by syphilis. You could get swellings in the mouth. You could get, it could affect your nervous system, your spine. So there are consequences to untreated sexually transmitted infection. So it goes in stages, right? Right? And then congenital syphilis, which no one wants to deal with, right? So we have a very robust antenatal and obstetric service in the maternal health service, and so thank God women are screened for syphilis, and so if they have syphilis, they're treated because you definitely don't want congenital syphilis, where syphilis can affect the baby, right, and cause all kinds of problems, which I won't get into right now. Okay? Next slide. Right? All ages are susceptible. Now, I told you about these stages, but you could pass through all those stages, right? And you could get to what we call latent, right? Where guess what? At the latent stage, no symptoms. So therefore, you've gone through all those stages, you still have syphilis, you are never treated, but now you have no symptoms. No symptoms, but you still have syphilis. Now, are you infectious? Not as infectious, but you can still, there's a possibility. And you should think as a clinician that you could be, right? So that's latent syphilis, right? You could only pick that up if you do special tests, right? And so a lot of people have syphilis and wouldn't know because they are at the latent stage, meaning it's hiding, right? All right, next slide. And I spoke about this. Very, 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 very sneaky, right? Now, they may also have swelling in the groin and fever and that stuff, but swelling in the groin, fever, a lot of people overlook things, right? They may have fever, feel muscle aches, but they may just disregard it. especially as men do. Right, Rev? And you shouldn't disregard things, right? Next slide. Right? And I spoke about, and I jumped the gun, secondary syphilis, right? You see that rash there? Next slide. And then I spoke about neurosyphilis too. It could affect the nervous system. It could also cause dementia if you have syphilis without treating it. And that is why I offer all my patients, would you like to do an STI screen? Doc, man, I had sex in so long. Man, you know, I'm a pastor. I give my life to Christ, you know. But these things could trail. These things could trail if not treated. Okay, next slide. And we spoke about that. All right. Trying to move a little fast. How many more minutes I have? And we spoke about latent, asymptomatic, scary. 5 minutes? 4? Okay. Next slide. And herpes. Herpes. Now, herpes is one of those conditions that you don't really screen for. It's not recommended that you screen for it. Because sometimes you really don't know with the tests that we do when you would have gotten herpes. But it's from sexual contact, direct contact with the source, the herpes source, if you're not having protected sex, right? Right? Yeah. Thanks for guiding me along. She's like, hurry. Thanks for guiding me along, right? You have these painful ulcers now. Once we as doctors see these ulcers, or you could have blisters, also little water bumps. Some people think it's water bumps. Once we see it, we kind of know that it's herpes, right? Right? And they could have fever and all the other stuff that could come with any sexually transmitted infection, right? And they burn, they're very painful, they're very infectious. The fluid in them is very infectious. They could be treated. Sometimes they could resolve on their own. So a lot of these STIs are very tricky. They're very tricky, but we can treat them. We can treat them with tablets or creams and all of that. Okay, continue. Right? Right? And the lesions may come back. Remember, for herpes, especially genital herpes, there's no cure. Right? Latent is the word I like to use, meaning it's hiding out. It can hide out in your nerves. It could go away and come back, especially if you're stressed or your immune system is not functioning properly. It reoccurs, right? So that is one of those STIs that is not curable. Chlamydia is curable. Gonorrhea is curable, right? Trichomoniasis is curable. That I'm going to get to briefly. But herpes, you could manage it, right? It causes a lot of distress, right? A lot of these STIs cause a lot of problems in the doctor's office because you have to, and as I said, you have to deal with it with tact, especially if someone brings their partner. They could break up your office because it could be, I had several cases what I had to deal with, You could have a fight in your office. A lot of things can happen. So as I say, young docs, handle things with great sensitivity. Next slide. Trichomonas, I think I'm going to end at this one. This is quite common, right? And docs, a lot of these things you don't need fancy testing for. As soon as you see it, you kind of know. That's what it is. So usually it's a malodorous odor, yellow-brown. It looks very frothy and very bubbly. And when you look in the vagina, in the cervix or in the vagina, it's very like red and fried. Yeah, you'll know it when you see it. Next slide. All right, and no, I'll end with this. Anal warts. Dr. Graham spoke about HPV, right, which is a virus. HPV can cause warts. These warts may be non-cancerous warts, right? But they're caused by strains of the HPV. Remember, she said 16 and 18. I think there are about 25 high-risk ones, but 16 and 18 cause cervical cancer. these warts, a lot of them are benign, not cancerous. But bear in mind that some of the, as she mentioned on her slide, that some of the HPV strains can also cause anal cancer, right? Anal cancer in men who have sex with men, females who have anal sex also, right? And so that is the case. And I got through the presentation. I was looking at you all the time. You didn't seem uncomfortable. Yeah. So I'll just stop there because the next slide I think was HPV, which is actually my favorite STI to talk about. But you took the thunder. Yeah, but I'll stop there. But what I like to say is that, you know, young docs, don't be uncomfortable talking about STIs. They're a part of life. It's reality, and we have to deal with it. Because if they're not treated, if they're not managed, if you don't screen for them, there are consequences. Right? Thank you.
Okay, thank you so much, Dr. Morgan, as that is a very crucial topic within sexual health. So to move on, for the sake of time, I'll introduce our third speaker, Dr. Nakia Forbes. And Dr. Nakia Forbes is the director of the Infectious Disease Program at the Ministry of Health and Wellness. She also serves as an infectious disease consultant at Princess Margaret Hospital and Doctors Hospital. She currently has full registration with the Bahamas Medical Council and Medical Council of Jamaica. Dr. Forbes graduated medical school from the University of the West Indies with honors in surgery and was the first recipient of the School of Clinical Medicine and Research, Researcher Cecile Bethel Award, as the top graduate in her class in 2002. During her postgraduate specialty training in internal medicine, she was appointed the chief resident in medicine at the University Hospital of the West Indies, Kingston, Jamaica. After residency, Dr. Forbes completed a fellowship in infectious diseases at the University of the West Indies Faculty of Medical Science in Kingston, Jamaica, in conjunction with the University of South Carolina School of Medicine. Dr. Forbes has made and continues to make substantial contributions in the leadership, teaching, and management of infectious diseases. She was named a fellow by the Infectious Disease Society of America, which is the nation's leading infectious diseases professional society. She is a fellow of the American College of Physicians and a member of the Society for Healthcare Epidemiology of America and the HIV Medical Association. She served as an advisor on the Ministry of Health and Wellness COVID-19 Task Force. She is the chairperson for numerous boards and committees, including the National HIV and AIDS Advisory Council, the HIV and AIDS Resource Committee, elimination of mother-to-child transmission of HIV and syphilis, elimination of mother-to-child transmission of HIV, syphilis, Pan-Caribbean Partnership on HIV and AIDS, also known as PANCAP, Priority and Action Coordinating Committee. She also has a membership of various boards and committees, including the AIDS Foundation of the Bahamas, PANCAP Knowledge Management Working Group, numerous committees at the University of the West Indies School of Clinical Medicine and Research. Dr. Forbes has been on the faculty of the University of the West Indies School of Medicine in the Bahamas for about over 10 years and was appointed to the clinical tutor in 2018. During this time, she is actively engaged in medical research and has built up on an extensive research and publication profile. She has done more than 100 lectures and presentations on various aspects of infectious disease, locally, regionally, and internationally. Dr. Forbes has been described by the Prime Minister, the Honorable Philip Brave Davis, as one of the best and brightest in our nation.
when thanking her for her contribution and commitment to the Bahamas. Dr. Forbes' focus for serving continues to be from a sense of gratitude. As she frequently says, God has equipped me to offer skills that are people-centered and quality-driven. So everyone, please welcome Dr. Forbes.
Well, thank you very much for that kind introduction, and it's always a pleasure to be here. I want to say a special thanks, and with pride, I look on to the future generation of doctors in the form of the UWI Bahamas Women's Health Initiative. So thank you very much. Next slide, please. So I will try to keep it brief, because I think there's some other activities that are planned for you. But this evening I'm going to talk about what is our situation on HIV and AIDS in the Bahamas and globally. And because I was asked to make this presentation something that is okay for the general public, I'm going to talk about what HIV is, what's the difference between that and AIDS. We're going to talk about how HIV is spread, what are the signs and symptoms, and how do you get tested? What are all the ways you can get tested and know your status? The very, very first step in staying free of HIV. We'll also talk about advancements in treatment. This has come a long way in 30 to 40 years. And then prevention. When we think about HIV and ending AIDS, it has to start with prevention. And then we'll talk a little bit about strategies to end AIDS in the Bahamas. I'll take some questions. Next slide, please. So, we monitor the situation with HIV and AIDS in the world, in the Caribbean region, and in the Bahamas. And so these are our most up-to-date statistics. And I say that because we follow these statistics on a regular basis. But at the end of the year, we collect a lot of information on new cases, on are things trending up or down, mother-to-child transmission. And since 2023 just ended, about between 3 to 4 weeks ago, then you know that we are busy now. Dr. Morgan and our team at HIV, we have our team at HIV here with us. We are busily preparing to do our report on how things look. And so in the world, in 2022, the United Nations reported that there were 36.9 million people living with HIV. Despite our advancements, there were still 1.3 million new infections. And sadly, 630,000 people died of AIDS, in that year. And remember when I told you that 36.9 million people were living with HIV, not all of them were on medication. Let's say that just under 30 million were accessing antiretroviral therapy. That's the drugs, the antiviral therapy to treat HIV. 29.8 million people were on that. So you see that there's a treatment gap still. What about in the Caribbean? What does that look like? There are roughly 330,000 adults and children living with HIV, and the prevalence is about 1.2%. There were 16,000 new infections in the Caribbean in 2022, and 5,600 people died of AIDS. And even one case is too many because we can prevent AIDS. And you can see that there's a treatment gap. 110,000 persons needed to be on medication or accessing medications. They were not. There were only 220,000 people that were accessing medication regularly. Next slide, please. And in our beautiful Bahama land, this is our most recent statistics. 3,943 people were living with HIV at the end of 2022. And what do we know about HIV? The population prevalence in the general population is about 1%. So let's say maybe 1 in 100 people may have HIV. But there are some populations that may have a higher risk. We call these key populations, and they could be young people, can be affected. It can be men who have sex with men. We found that there was a higher prevalence in that group. And there are other people who could be at risk for HIV infection. We're going to talk more about that. What about our trends? So if you can see in the bottom corner on the right, that's a line graph. And so in the orange are female cases, and in the green are male cases. And we've been recording and reporting on the HIV epidemic from since the beginning of the HIV epidemic in the Bahamas. That was in the early 1980s. Let's call it around 1983. And so you can see that we have had, there's no pointer, so forgive me for pointing, that we had a peak here in 1993. I'll tell you, there were just under 800 new infections that year. There were 797 new infections, but it's gone down a lot because of the work that the center, the team, the government has put a lot of resources into this, including free medication. So we've seen that there's been a big decline. And we are seeing some decreases in HIV in the new cases. And so in 2021, we had 112 new cases. 68% of those cases were male, and 32% were female. And so we are seeing tremendous declines. Let's talk about HIV. It is a virus. It's an abbreviation for human immunodeficiency virus. So H, it affects only humans. It causes an immunodeficiency. That means that the immune system is weakened, and that increases the risk of infections. So we all come in contact with microbes and organisms, whether that's viruses, fungi, protozoa, bacteria. But most of the time, if you have an intact immune system, you may not get seriously ill from some of these things. But if your immune system is weakened, like in the case of HIV in the advanced stages, AIDS, persons can get very severe infections and very sick. And the V is for virus, because the virus attacks the body. This is very different than AIDS. So we hear HIV, AIDS, and sometimes we hear someone say, oh, that person caught AIDS, but that's not really quite so. So we've been hearing from Dr. Graham, from Dr. Morgan about viruses. So HIV is the virus that causes the HIV infection, but AIDS is quite different. AIDS refers to the advanced stages of HIV infection. That can happen if the person does not get treatment or effective treatment. And this is also an abbreviation for acquired immunodeficiency syndrome. So it's acquired, it will happen over time. It's not like a genetic disorder. It affects the immune system. It creates a deficiency. That means some of the cells in the body, think back to science in high school, there were different cells, red blood cells, white blood cells, platelets. That platelets stop bleeding. The white cells are sort of like, I think of them as a protection for the body. It protects against cancers and infections. And so there's a deficiency of a certain type of white cell in these advanced stages of HIV called AIDS, and it's a syndrome because it's a group of illnesses taking place at the same time. Next slide, please. And press the button again. And so, as we said, in the interest of time, AIDS happens when the immune system is weakened. There are two strains of HIV, HIV 1 and 2. HIV 2 is a bit milder. We don't see a lot of that in our part of the world. But how is HIV transmitted? So this, sorry, I have to keep up with you. Next slide, please. Yes, so this infection happens only through certain activities when a person comes in contact with certain bodily fluids. And those fluids include blood, semen, ejaculatory fluids, rectal fluids, vaginal fluids, and breast milk. And these fluids must come in contact with a mucous membrane or damaged tissue, or injected directly through the bloodstream. Next slide. And so you can keep pressing. So you can see here the picture. So that means that HIV can be transmitted sexually. That's the main mode of transmission in our country. It can also be transmitted from mother to baby. And this can be when the baby is in the uterus, or more commonly, it's usually at the time of delivery with all the blood and fluids that will be exposed to the baby's mucous membranes. And it can also be transmitted by IV drug use or needles. Next slide, please. But most importantly, HIV is not transmitted in the ways that I put on this slide. And I always include this because there are a lot of myths about HIV transmission. And so it can't be transmitted by coughing and sneezing, insect bites. If a mosquito bites somebody who has HIV and then bites you, cannot get HIV like that. Casual contact like touching and hugging will not spread HIV. It will not spread through water or food. If you share a drink, a soda, if I say, Dr. Morgan, can I have some of your water? HIV will not be spread by sharing sodas or drinks on a hot day. It will not be spread by kissing or even living in the same household and sharing glasses and household items, or working with someone who has HIV is not going to spread it. Neither is going to school with someone, or using phones, or sharing utensils. Even in this day and time, we hear stories about stigma and discrimination. Sadly, that someone may be working in the workplace, I work along with that person, I'm not thrilled about that, or providing care. In providing care, where a lot of us are caregivers, giving a hug, encouragement, that will not spread HIV. Or even sometimes, sadly, on schools, sometimes we hear that if someone finds out that they are living with HIV, that there can be discrimination. So this is the ways HIV is not transmitted. Next slide, please. I'm going to rush through this, but basically there are stages. We heard so much about stages. That should be the key word for the evening, right? So you cannot really tell necessarily that someone has HIV infection. First of all, let me start by that. Many people are asymptomatic and can look very healthy, should look very healthy. So what happens when someone first gets HIV, when they first get the infection? They may have some symptoms. It's called acute seroconversion. And that's just like a cold or flu. Fever, sore throat, you could have swollen lymph nodes, feel tired, very exhausted, chills, for example, sore throat, but that will go away. And because it sounds a lot like a cold or flu, most people think it's a cold or flu. And you don't necessarily go to your doctor for that, right? And then there would be a long period where the person has no symptoms at all. Could be years, 8 to 10 years. Yes. So, sometimes when you might be meeting someone or dating someone, say, oh, they look okay. That doesn't really quite work, right? We're going to talk about that when we talk about knowing your status. And then after time, when the immune system becomes weakened, that's when the individual can start having symptoms, right? And some of those symptoms may be tiredness, weight loss, infections like frequent chest infections. It could be yeast or thrush infection in the mouth. It could be skin rash, tuberculosis, maybe harder to treat. It can cause diarrhea, a lot of weight loss. Those are some of the signs that we may hear about. And then in AIDS, this is very unusual infections, like certain brain infections or thrush in the esophagus, the swallowing pipe, for example. But in the interest of time, we won't go through too much of that. But in the advanced stages is when we start to see symptoms. Next slide, please. And I'll skip through that. I want to talk a bit about this thing called viral load. So that's the amount of HIV virus in the person's bloodstream. We measure it. We measure it because we want to know how many copies of HIV is in a tablespoon of blood. Why? We want to know where we're starting from, and this is also something that we measure so that we can tell how effective our treatment is. We're going to talk more about that. Next slide. And so as HIV progresses, the amount of virus in the person's body increases. We say they have a high viral load. And remember I talked about the white cells that are protective? Those get destroyed by the virus. And so those white cells will go low. It's called a CD4 count. And the person may have symptoms. Next slide, please. I'm going to skip this. We talked about AIDS already. Next. And so let's talk about HIV status. And do you know your status, and HIV testing. And so it's very, very important for people to know their HIV status. And so I stand on some of the things that Dr. Graham said and Dr. Morgan, because persons can get HIV on their first sexual encounter. And so we have to stop thinking about STIs. Yes, there could be a risk if there are an increased number of partners, but we also have to consider that they're spread by sexual contact. And we do hear a lot of stories of persons that can have multiple partners. They may not have multiple partners. Their partner may have multiple partners. And so it's very, very important to know your HIV status. Next slide, please. Stressing the computer out. So testing is really the only way to know your HIV status. You can't rely on symptoms because many people are asymptomatic. And persons with HIV can look and feel healthy. And there are many testing options available. So there are oral testing methods where the test looks a bit like a swab. You open it, you run it across the gums on the top and the bottom. You put it in the solution, and in about 15 minutes, the test will say whether it is reactive or positive or negative. There's also a blood test. And these things are very fast. So in my slide, I showed a rapid blood test that it uses a finger stick and a little drop of blood. Our team knows all about that. In 15 minutes, you'll have an idea if that's reactive, positive, or not reactive. And this is available in minutes. No need to take a tube of blood and wait for 3 days or a week. You could have the result in minutes. And it's confidential, discreet. And we recently in December launched oral HIV self-testing. And those will be available in your pharmacy shelves, that you can do this at home in a place where you are comfortable, and it is confidential and very private. And it is, that test is a test as triage. We're just finalizing the supplemental material, but that test is going to be available very, very, very soon. If that test is positive, you still need a confirmatory test. So for each HIV test, the first test requires confirmation. Okay? Next. And so what happens if the test is positive? So if the test is positive in, I would say, sometimes that same day, if we could get back some of the lab results, we can start people on effective treatment. And HIV treatment has come a long way. So for persons who provided care and know about HIV treatment, when this first started in the 90s and the late 80s, it was a whole handful of pills. It was maybe 10 pills. You had to take it 3 times a day. There were a lot of side effects. But now HIV treatment can be as simple as 1 pill once a day. Very effective. Yes. Very good medications. Very low side effects. They work very, very quickly. They have minimal side effects. They've been around for a long time. They're safe, and they are free. They are free in the Commonwealth of the Bahamas through the National AIDS Program. The government of the Bahamas has always made these medications free, and we provide them in many places. We provide them at our center. They're available at the Princess Margaret. We're trying to roll them out in other locations. They are at treatment sites through your private physician, and they can be obtained free of charge. Next slide, please. And so this is very exciting. They work so well, they can bring that viral load down to the point where in the blood sample, when the doctor takes the blood and sends the blood to the lab, in 1 teaspoon of blood, there are no detectable copies of the virus in that spoon of blood. In 5 mils, it's called undetectable. Very, very important. Very important. And if you know someone who has HIV, if you're the support mechanism, if you're living with HIV out there and you're on treatment, check. Make sure your doctor is making sure that your viral load is undetectable. And that test is also free through the reference lab in the Bahamas. And I sometimes give an example. If you have high blood pressure, you go back to your doctor and check your blood pressure's target. If you're diabetic, Doctors check your sugar. You want to check your sugar at home to make sure it's between those magic range of numbers, so your sugar is controlled. There's a HbA1c. Dr. Graham was talking about tumor markers and how to monitor that things are cured. Well, HIV is also, you don't just start medication. You want to know that the person is doing well, that they are free of symptoms, that their viral load is undetectable, and their good white cells are rising. And so there is actually a bit of science behind this undetectable viral load, and we have found out that people who have an undetectable viral load that remains undetectable, a sustained undetectable viral load, that HIV is untransmittable with the undetectable viral load. And that means that it cannot be transmitted from mother to baby. So we're seeing an AIDS-free generation. No babies born for about 5 years for women who were on effective therapy. Or that we're seeing that it cannot be transmitted to partners. Even if a condom is not always used, it can be transmitted in any means. But the key is the viral load must be undetectable. It must stay undetectable. That means the person must stay on medication. Next slide, please. I'm going to end by talking about our fight against HIV, and in solidarity with all the UN member countries in the world, we are on a fast track to end AIDS by 2030. So that HIV and AIDS can no longer be a problem. And how are we going to get there? There's a scientific model, and that if we can have as many people as possible knowing that they have HIV, right? Because that's the first step. If you know that you are living with HIV, you can get on treatment. If you know that you don't have HIV, you can take preventative steps, right? So 95% of people should be aware of their status. 95% of them should be on effective antiretroviral therapy, that's medication, and 95% undetectable. If all the countries in the world could do this, there'd be few cases of HIV. This would eventually become something that would dwindle out. It wouldn't be such a huge burden, right? Where we're seeing millions of new infections per year. So we are making some progress. And so I can tell you that we saw at least, actually, I should update this slide. This was from a previous presentation, that the last time we talked about this, 93% of people in the Bahamas knew their HIV status. Yes. So that was excellent. That was very, very, very good. Right? And we've come a long way, because we have about 4 out of 5 people who are on effective medication now. That's definitely come a long way. But we have a ways to go. And viral suppression was about 81% when we last looked at this in 2022. But we still have a ways to go. Next slide, please. And so I'm going to end by talking a bit about HIV prevention, because that's how this all starts. So still, after knowing your status, if the test is negative, how do you keep it negative? Right? Because there are certainly a lot of risks for getting HIV. And so there is a pill. There's actually a daily pill. It's called PrEP. And this pill is an HIV prevention strategy in which a high-risk HIV-negative individual takes this medication daily to prevent infection. In some situations, we can give this, it's called event-driven PrEP. It's PrEP 211. And that depends. And people who don't have sex that often, less than twice a week, if they can predict that they're going to have sex, that they can take the PrEP about 2 hours before having sex, 2 to 24 hours before having sex. You take it every day that you're sexually active, and then you take it additionally for 2 days afterward. And that has also been proven to be effective in some couples. And there are many other ways. So this is one innovative way, but there are many other ways to prevent HIV infection. And that could be condoms and lubricants, using condoms properly throughout the entire act from beginning to ends, not removing it in the middle, using a water-based lubricant because oils and Vaseline can cause the condom to burst, knowing your status. What about couples testing? And if you do not always consistently use condoms with multiple partners, maybe you're a candidate for PrEP. And then there are many other things like the social determinants of health and There are people who are in situations that they do not always control. They would be candidates for PrEP. And there's a combination approach for this. There are many other ways. And why do we need them? Because there's no single approach that's 100% perfect, effective, and efficacious, except abstinence, which may not be easy for some people to do, right? And so that is why we have a combination of approaches. Also, if sex has happened, suppose the condom broke or there was no condom used or there was a situation, there's something called post-exposure prophylaxis. You can come and see one of us. You could go to your doctor, but you must do this within 72 hours, before 72 hours of the condom breaking. Ideally, the earlier the better. And we can then do some testing, we can do some risk stratification and offer some medication. So in case the person came in contact with HIV, we can offer these medications for about a month, and that will reduce the chance significantly of getting HIV. And then after that, the person may wish to go on PrEP. We also have those medications free of cost at the center, and our trusted providers are equipped to provide those. So I'm going to take a step back from all the science and the medicine of HIV, and I always say, you know, I guess I'm getting a bit older, but I've been doing this for a while, and when we think about why HIV hasn't gone away, it's because it's not just a medical issue. It's a complex social issue, right? Because sex relies on things like trust and things like that, which can be broken, and other things. And so HIV is also shrouded. Unfortunately, there's a lot of stigma and discrimination around it. And so thank you all for coming tonight and showing your commitment in the fight to ending AIDS and organizing this. And when we think about how to fight HIV and AIDS, it's not just a medical issue. So we have to raise awareness and talk about prevention and be willing to have conversations about how to protect sexual health and have frank, honest conversations, including age-appropriate conversations. There are vulnerabilities and inequities that make people at risk for HIV, and we do have to address those too. Know the facts on HIV, and we have to promote a culture of compassion and care and fight stigma and discrimination, because we have made tremendous headway, but there's still a lot of that. Next slide, please. And so my last slide is really some posters on how to end inequalities is key. And so we have to stop stigma. We have to stop discrimination. It stops with every one of us. And things like biases and so on, it has to be openly addressed. You have to think about, do you have bias? Sometimes as a provider, do you have bias? Because it can be noticeable in treating vulnerable populations. And so we do need to make sure that we treat everyone with respect. And so I really like this poster. And HIV is a virus, and it has no race, gender, or sexuality. And then you see, and here's this fellow, he's really a champion for HIV, and waving the flag to stop discrimination. And then we see the cartoons in the red, all the things that we have to fight against to make sure that we end the discrimination that's contributing to HIV. And so what do those say? Homophobia, gossip, and shame, bigotry, fear, and ignorance. So we have to root those out. And so thank you very much. And I have one more slide. So in summary, HIV and AIDS are still a concern in the Bahamas. We are making gains. HIV is a virus that leads to progressive immune system decline, and AIDS is the advanced stage of that infection. HIV is transmitted mainly sexually in the Bahamas, and we are making strides in reducing new infections, and we're seeing less persons die of AIDS. We have almost eliminated mother-to-baby transmission, and HIV is preventable. And the treatment, care, and support in the Bahamas is free of cost to the client. Thank you very much for inviting me to be a part of this esteemed panel, and I'll take any questions you have.
Forbes, thank you for the presentation. Refer to ending HIV/AIDS in the Bahamas by 2030, 2024. That's an aggressive gamble.
Yeah, thank you. I mean, let's go back to the 95, 95, 95 slide. I think there was another, yeah, perfect. All right, so you know where this all came from? It came from a scientist. And he sat there, you know, scientists need time to think, they say, right? So he said, despite all these advancements in HIV, one pill once a day, it can work in 12 weeks to get someone down to undetectable. And then HIV can be transmitted. Well, if we've made all these advancements, why do we still have HIV? Why were there 1.3 million new cases in 2022? And so let's think about it for a minute. Let's take a step back from all of these statistics because they get a little, it's very, very granular, these statistics, right? But think about it. If someone has HIV, they don't know about it. If they haven't had an HIV test, right? And if you don't know about it, you can't do anything about it. You don't change behavior. You might have new partners, not use protection. And you also won't get in treatment. The person won't get on treatment, right? And then there's no chance then if they're not on treatment for their virus to be treated so that it's no longer making copies. And so the virus would easily be spread sexually, mother to baby. And we heard that there's 36.9 million people living with HIV, right? And so how do we solve that? How do we solve the problem? And it's very complex, but if we say, okay, let's just look at that spectrum or that continuum. If we could get persons to know their status, as many people as possible to know their status. If you have HIV, you can go on treatment that's effective. That prevents new cases. You follow? If you don't have HIV, but you have high-risk behavior, multiple partners, you're not always using condoms, your partner might have multiple partners, the condoms are not used appropriately, you can do something. You can do prevention. There's a lot of ways we talked about, including the prevention pill now, right? But say the person is positive, they get on treatment, and they stay on treatment, their viral load becomes undetectable. So if we get as many people on treatment as possible, and as many people have an undetectable viral load, that will then significantly reduce new infections. And then there are many scientists do different things. There was a model. So this was a road. It wasn't just like bam in 2022. We're going to get here by 2023. This actually started in 2013, more than 10 years ago. So the model was created, and they said, okay, if the majority of countries can try and target getting 90% of people to know their HIV status, 90% of those people on treatment, and 90% virally suppressed by 2020, if we could do the hard work in the short term, that was 5 years, then we'll have 10 years to finish, to close the gap, to get to 95, to the final 5%, 95, 95, 95. So we had to front load all the hard work, right? It's almost like rolling something up a hill, right? And then when now you have to roll it down, hopefully it'll be easier now, right? You have 10 years to try and get to that gap. And so it wasn't an overnight thing. So as much as, yes, it's a very ambitious target, and it was recognized this was an ambitious target, and it's a worldwide target. All the 193 UN member countries signed on and agreed to this. And I'll tell you honestly, when we started this in 2015, well, you know, again, we had to finesse and improve the way we were getting information, all right? But when we started this in 2015, maybe, let me see, what were those numbers? 78% of people knew their status around that time. And treatment coverage was not, the amount of people on treatment is not what it was now. Okay, it was much lower, although we changed strategies to put everybody on treatment regardless of their immune system. That wasn't happening all the way back then. The world wasn't doing that. And then this undetectable viral load, we do all the things to support that. Make sure people stay on medications. Medications are free. Look at side effects. Bring medications to people. Ask providers to do these viral loads. And so we've actually made tremendous progress. And so you're right. I wish we could get to 95, 95, 95. There was a report card in 2020 for all the countries in the world, and very few countries in the world did get to that 90, 90, 90, but a few did. But in the Bahamas, at our last, in 2022, when we reported on this, 93% of people knew their status. We'd improved significantly in some cases. In women, 80% of them were on medication. 4 out of 5 were on medication, and viral suppression improved tremendously from 60-something% in the year before to about 81% that year. And so we are making some strides, but there is still a long way to go. You are very right. We have a long way to go, and we need help with that. When you said to me, help me with that, Dr. Forbes, we need everybody to help with that, because how we get there is fighting stigma and discrimination so people can come in and feel like they can get a test. Making tests accessible and innovative. Self-testing. There's free testing at the reference lab. There's free testing at the center. Supporting persons. If people need counseling, if you could say, I can help you go in. If you know persons who are living with HIV, pastors are here, help them in the congregation. Sometimes you need a buddy to go to the hospital with, or go to the doctor with, or get my medications for me, or could you pick up some food for me because proper nutrition is good, right? And again, our trusted providers and our team, all of what they do. So we're working on it. I would like to see us get there. I think we can get there. Sorry, that was a long answer, but it's hard to answer that one short.
Touched on the pre-exposure prophylaxis, but for a couple that may be monogamous and serodiscordant, the positive and a negative partner, I imagine that would create kind of a sense of security if the positive partner is undetectable. So in that circumstance, are couples still encouraged to condomize and to use the pre-exposure prophylaxis?
Well, every couple is different, so we individualize it. And so there are some couples who are serodiscordant, as you said. One part of the couple is HIV positive, the other person is negative. And the positive partner has an undetectable viral load and has always had an undetectable viral load for a very long time. They do not always have to use condoms, but it depends. So usually the couple will come in and they'll have a consultation, and they'll decide what it is that they want to do, and every couple is different. Some say, oh no, we use condoms all the time, and we're comfortable with that. And some say they would like to do PrEP, and that's okay too. But in every scenario, it's individualized. You're welcome.
We have a few questions that came in from the public. So one of them is pertaining to AIDS and STIs. A lot of people are experimenting these days. Does anal sex have a higher risk or the same risk in women than it does in men?
Yes. So with anal sex, there is a higher chance of HIV acquisition. STIs can also affect the rectal and anal tissues and areas. And so we also, there's anal health. There's anal health, anal paps, anal exams. There can be warts. Yes?
So these other questions are open to the panel, so I want the panel to answer as well. So what advice do you have for parents who know their kids are sexually active or may think or suspect that they are?
Which panelist is that for? You'll have to give that to us. You'll have to tell us which person you'd like to answer. I'm going to go back to my seat so you can decide.
So, I guess I'll throw this question out to Dr. Morgan since she spoke about STIs.
Okay, let me hear it one more time. Sorry.
Okay. Let's take the So the question is, what advice do you have for parents who know their kids are sexually active or may think or suspect that they are?
Well, so parents have to talk. Parents have to talk to their kids. And as with STIs, you have to be open, you have to be frank. You have to tell them about the dangers of unprotected sex. And I guess this is age specific, right? Tell them about the dangers. STIs are possible. A range of STIs, some treatable, some curable, but some like HIV just manageable but not curable. Just to have an open discussion about the reality. There's no use hiding it, and you know, there's no use in suspecting and shying away from it. You have to be open, because they kind of know a lot from what they watch, from what they talk to with their classmates. So just have a very stern, frank, open, honest discussion about the reality of the consequences of making poor sexual health choices. And you know, it's very important. Kids listen, you know. Kids do listen, believe it or not.
Thank you, Dr. Morgan. Another question is, if I had my first child at 18, does that mean I have to take a pap smear earlier? I'll direct this question to Dr. M. I guess it is.
The guidelines for beginning a pap smear is at the age of 21. Now, previously to those recent guidelines, when I was in medical school, you were taught that once the patient is sexually active, you do a pap smear, whether they have reached the age of 21 or not. But with that too, you're finding out. I mean, we know that young people, like Mike mentioned before, are experimenting before time. If we go to pap smears on all of these patients, we'll have almost all of them, well, no, not almost all of them, but quite a few of them will have abnormal pap smears. With the abnormal pap smear, you're forced to act. Because as I mentioned in the presentation, when you have an abnormal pap smear, specifically if it's all of those things except for an ascus, you go straight to colposcopy. And depending on what the stage is, you may find yourself treating and taking off a portion of the cervix from, 14, 15 years. And so by the time, even though her sexual debut or having a child would have been at the age of 18, she would have already had probably some procedure to manage so it doesn't progress to cervical cancer. And so we tend to, and in the younger population, it's very, because their immune system is better, they clear the virus very easily. All right, so, but if you go doing pap smears, then you find out that there's an abnormality, then you're kind of forced to to manage, and some of them may be do an excisional biopsy or something like that. And if you start that at a young age, you'll have other complications such as cervical incompetence in the, when you're trying to have your family then. All right.
Thank you.
Okay, this question is for you as well. Can the human papillomavirus still be present in your body even if visible genital warts are no longer present? How long could it stay in your body, and what are the symptoms?
Okay, there are two things you need to know with respect to an HPV. As I mentioned earlier, you can have an infection and it clear, depending on your immune status and things like that. Now, there are a subset of young people who can have a persistent HPV infection. And I mentioned earlier when I spoke even about an older person, they can clear the virus or it can be persistent and it can lie dormant in your system. Now, how, it's there, viruses are there, the human papillomavirus. All right. Now, the human papillomavirus is a little interesting in that, we are taught in medical school once you have a viral infection, you have it. But in the younger population, it has been shown that they can clear the virus. All right. And hence the reason why we don't go doing pap smears at a young age for those. As you get older, your immune system isn't as good, and you may have a persistent infection and not clear it. There are some younger people who have persistent infections and don't clear it. Not to say how long it could stay in your system. It depends in the younger patient, but usually the HPV is cleared, if you're going to clear it, at 6 months or more. Hence the reason why we repeat your pap smear in 6 months in the younger population. We don't do HPV statuses in patients younger than the age of 30. Okay, so in those patients, we just repeat the pap smear in 6 months. And in a lot of cases in the young people, it reverts back to normal. So at the age of 21 or 22, if you had an HPV infection, chances are you may clear it. All right, and so you can clear the virus. And this is why even if you didn't have your vaccine as a child between the ages of 10 and 12, we still encourage you to get the vaccine even though you're outside of that age bracket that the guidelines said, because you can still have some protection. And so if you come to me and you're at 20 some out of the age bracket or 30, I still give the vaccine because you can get some protection. Okay, I hope I answered that question.
Yeah. So another question is, if I'm a teen and I want to get tested, do I need my parents' permission or consent for testing? Well, HIV and STI, so I'll direct it to both Dr. Forbes and Dr. Morgan.
Well, thanks for that. That's a very good question. And so in the Bahamas, the age of consent for medical care is 18 years old. However, the age of consent for sex is 16 years old.
Wow.
The Bahamas is not the only country where there's this disparity. And so I would say legally, until 18 years of age, it should happen with either parental permission or a ward to give permission for those tests to be done. But we do see that there is this gap, and we know that young persons are sexually active. And so there are some efforts, not just in the Bahamas, but in many countries. This is a situation in lots and lots of countries to try and align the age of consent. The age of where young persons can get tested without parental permission or without someone that has brought them in and will sign permission for them to get tested. I do encourage young persons, and we do have to have honest conversations about sex and protecting young persons. So for parents that are out there and listening, please do talk to young persons about sex. And if you're sexually active young persons, please do make efforts to protect yourself, including condoms, lubricants, knowing your risk. If you are having symptoms, you should get medical care and attention. And you should tell somebody that you can trust so that that can be navigated. Did you want to add anything?
No. Okay, thank you so much. That was our question and answer. Does anybody have any other questions they would like to ask? Okay, we apologize for not introducing ourselves. My name is Mavanda Green. I'm the research officer.
And my name is Anika Menes. I serve as the vice president.
Okay, thank you so much.
Okay, so thank you guys so much. We've reached the end of our session. I know we went a little over time, so I just want to thank our panel for staying, and I also want to thank you all for being really great audience members. We also just have a token of appreciation for our panel, so we could just call you up one by one, and then we could just take a photo with the executive, and then that's it. So, okay, we could go to Dr. Morgan and Nadia. So the rest of the executive could come, yeah.